As a medical student, and also at the beginning of my medical career, I always had the impression that restrictive cardiomyopathy was one of those diagnoses which are simply overrepresented in textbooks. You read about the different causes of restrictive cardiomyopathy, for example, morbus gaucher, and you kind of realize that you'll probably never encounter this disease in your entire life. Still, even though it's a very rare disease, at least in our country, we don't see very many patients with restrictive cardiomyopathy, it's probably underdiagnosed. But you can find this disease, and you can find it with echocardiography. I will now show you which typical features we can find in these patients and go through this chapter and explain you what the importance of the disease actually is. Restrictive cardiomyopathy is actually a bag of different diseases. But as our understanding of the diseases changes, so does also the definition and the classification. But let's first stick to the definition that we use presently. Restrictive cardiomyopathy is an idiopathic or systemic disorder. The primary problem is diastolic dysfunction, and systolic function is usually normal or only mildly reduced, at least at the beginning of the disease. Both the left and the right ventricle are involved. It is classified as non-infiltrative, infiltrative, caused by storage disease, or endomyocardial. If we look at specific causes, the most common cause probably is amyloidosis, followed by idiopathic, sarcoid heart disease, endomyocardial fibrosis or hypereosinophilic syndromes, and radiation. Further causes include chemotherapy, carcinoid heart disease, and hemochromatosis. Because these different diseases vary with respect to their incidence in different countries and geographical regions, we also have a different prevalence of restrictive cardiomyopathy depending on which country we're talking. For example, in Mozambique, where endomyocardial fibrosis is quite frequent, we have a fairly high prevalence of approximately 20% of the population. In the Western world, the prevalence has been reported to be much less, even though I believe it's probably an underdiagnosed disease, simply because it's sometimes very difficult to diagnose restrictive cardiomyopathy. The prognosis is poor. For example, in amyloidosis, the median survival is only 2 years. Unfortunately, there are not very many therapeutic options. You can try specific therapies if they're available. For example, for amyloidosis, you can use ankylation agents, or for hemochromatosis, iron chelation therapy or venesection. And there's a number of other drugs which have been tested, but basically once you've made the diagnosis, the patients are not very well off. I already mentioned that diastolic dysfunction is the primary problem in restrictive cardiomyopathy, but I personally believe that these patients probably also have systolic dysfunction in the early stages of the disease, and there is evidence for that if we look at myocardial mechanics and specifically at longitudinal contraction, but we'll talk about that later. The ventricle in general is stiff, so we have a filling problem. This is also reflected by elevated filling pressures, and very often we also have involvement of the right heart, so the prominent feature often is right heart failure in these patients. So what we often see in these patients is hepatomegaly, peripheral edema, pericardial effusion, and pleural effusion. It is important to understand that a restrictive filling pattern is not the same thing as restrictive cardiomyopathy. You will find a restrictive filling pattern also in other conditions, such as dilated cardiomyopathy, where it only denotes that you have an elevation of left ventricular filling pressure. And you will also find other forms of diastolic dysfunction in patients with restrictive cardiomyopathy, especially at the beginning of the disease, for example, a relaxation pattern or a pseudonormal pattern. Because of several similarities, restrictive cardiomyopathy and pericardial constriction are often discussed together. Patients have similar symptoms, a similar physiology, both have filling impairment. In restrictive cardiomyopathy, because the myocardium usually has some infiltrative process, while in pericardial constriction, because the pericardium does not permit expansion of the left ventricle, and the echo features are somewhat similar. Keep this in mind. We'll discuss the differences and the similarities later. So what are the typical echo features? First of all, left ventricular hypertrophy. Remember, it's an infiltrative process, at least very often, and this causes left ventricular hypertrophy even in the absence of hypertensive heart disease. Volumes and the size of the left ventricle are usually normal. We have normal left ventricular function, at least at the beginning of the disease process, and a very typical finding is biatrial enlargement, simply because the patients have a filling problem and thereby left ventricular filling pressures are elevated, which causes increase in the size of the atria. Both the left and the right atria are often enlarged. Other findings which also denote elevated left atrial filling pressures are expanded left atrial appendages and enlargements of the pulmonic veins. On the right side of the heart, you will find a dilated vena cava inferior, as you can see in this example, which usually is caused by right heart involvement and elevated right atrial filling pressures. And very often you also find tricuspid regurgitation, which also contributes to a dilatation of the vena cava inferior. Because diastolic dysfunction is so important in patients with restrictive cardiomyopathy, just a short review on how we grade the different severities. In patients with restrictive cardiomyopathy at the beginning of the disease process, you might only find mild forms of diastolic dysfunction, such as abnormal relaxation. But as the disease progresses and left ventricular filling pressures rise, we have more severe forms, such as restrictive filling patterns. In patients with restrictive cardiomyopathy, during inspiration, we have a further shortening of the deceleration time, which also denotes an increase in left ventricular filling pressures. If you perform post-wave Doppler of the hepatic veins, you will find flow reversal upon inspiration. Restrictive cardiomyopathy is the classical indication for tissue Doppler of the mitral valve annulus. Because left ventricular filling pressures are elevated, we have small E' waves in patients with restrictive cardiomyopathy. This is in contrast to patients who have constrictive cardiomyopathy. So here we are again with comparing restrictive to constrictive. And one of the typical differential signs is that we have a preserved E' wave in constrictive cardiomyopathy. This is what we mean by the paradox of tissue Doppler in constrictive pericarditis, where E' is preserved despite elevated left ventricular filling pressure. Again, this is in contrast to restrictive cardiomyopathy, where the E' wave is small. A lot of theoretical stuff, I know, but we need the stuff to understand the specific forms of restrictive cardiomyopathy, which will now be the issue of the following chapter.